All right, everyone, welcome. Joining us once again for our Lymphatic Therapist webinar series through the Boston Lymphatic Center. We're lucky to have Katrina again today. She's going to be going through our breast cancer lymphedema surveillance program, which has been kind of an evolution, I'd say. Katrina will go through it in more detail, but has been something that Dr. Singhal has really felt was so important to have a really comprehensive center, was that we were getting these patients early that were high risk to develop lymphedema, making sure they were getting the intervention to try to decrease the risk of more severe lymphatic symptoms. So, Katrina, I'll flip over to you, and then we're happy to take questions at the end as time allows.
Hi everyone. My name is Katrina, like Brett said. I'm one therapist at Beth Israel here to assist patients for lymphedema. So briefly, we're just going to go. Oh, there we go. So just quick outline. So we're just going to go over kind of background of our program here and kind of some problems that we ran into and how we're going to fix them, and then just some conclusions and future directions of where we're going to go with our center. So just as a background, since 2016, for patients who are undergoing axillary lymph node dissection are also getting an immediate lymphovenous bypass, or what we call ILR, basically to help kind of reduce the risk of patients developing lymphedema. So basically, this retrospective study was done as kind of a look back of the past kind of 4 years of patients that have undergone an actual lymph node dissection and an ILR, and we've found that it's a 9% rate of patients developing lymphedema, and this is kind of a similar rate that other institutions have seen as well. So basically, our program here at BIDMC, basically how the patients are followed up here with us, all the therapists. They're seen preoperatively before their surgeries for baseline measurements. So they're seen and we track their volume, bioimpedance, functional status, range of motion. And then they're actually followed with us for 4 years postoperatively. So they're seen at the 4 to 6 week mark, and then at every 3 month intervals for 2 years, and then 6 month intervals for 2 years. So it definitely has a pretty rigorous follow-up afterwards to try to catch patients early and all of that. So that's just brief outline of our program. For tracking purposes, we use a volume by parameter, which is the photo on the left, to track the patient's volume. If they can't get into that 90-degree of shoulder abduction, which some people can't, then we'll use a tape measure to track their volume. And then for bioimpedance, we use the SOZO machine, which is that picture here in the middle, and we use the LDEX reading. So this kind of graph here on the right is basically a screenshot of what the LDEX numbers look like. And basically this is just tracking their fluid in their arm. It's comparing it, their at-risk arm, and kind of compares it to their normal arm or their non-at-risk arm. So basically, we've kind of found that a lot of these patients after surgery, if they are kind of either developing symptoms of lymphedema, they kind of trend upwards mostly with the LDEX here. We're always tracking the volume too, but we're learning just from looking back at a lot of patients that they mostly kind of trigger up into the LDEX measurement than necessarily the volume. Sometimes the volume will follow afterwards, but it's mostly the LDEX that we see that initially will go up. But basically, if you can see here, there's a kind of a straight black line, which is that patient's their personal baseline of what their LDEX was prior to surgery. So then basically we're kind of tracking based on their personal baseline. And really, if the LDEX gets kind of 6.5 points or greater than their baseline, then we initiate compression, which kind of puts us into this yellow zone here. So kind of this measurement right here. Or if the relative volume change, or our RVC, is 5% or greater, which is basically just tracking their volumes from their initial visit and tracking to their current volumes at that visit. So basically, if they show kind of either of these numbers, again, 6.5 points or greater, or a 5% RBC, then we put them into a compression sleeve, and that's kind of our first line of defense. And obviously, our hope is that once we do that, then they could potentially go back down excuse me, back down to that green zone, and then maybe we could potentially wean them out of compression as long as they kind of stay in that area. And we'll talk more about that later. Um, So what we found is that, you know, obviously the rate of lymphedema again after the surgeries was 9%, which is pretty remarkable compared to I think it's around like 30% if they don't have the ILR. So it's definitely a huge decrease. But I think, when we were looking at the study, we kind of realized that we're not sure if it's necessarily due to the ILR part of the procedure alone, or if it's because we have the surveillance program that we're following these patients so much during the initial phase of, after their treatment, after all of their cancer treatment. Um, so is it because we're intervening so early that these patients aren't developing lymphedema? Because sometimes even, when a patient kind of gets into this zone here, they actually may not even have any symptoms. So we're actually catching it even before they have any symptoms of lymphedema, right? Um, it's kind of hard to tell like what exactly the success rate was from. Is it from the ILR or is it from because we have the surveillance program? So basically, we're trying to figure out kind of what we do for these patients that are also kind of in this in between zone, right? So they may not have symptoms, but or they don't have a lot of edema, but obviously something in their, like there is extra fluid in the arm, so it should be managed. And kind of what we do for those patients as well who are not, super severe where they would need like a course of treatment, or it's kind of like these in between people, and kind of what we do with them. And we're kind of naming it almost as like our yellow zone, and we're really just basing it off of the green, yellow, reds that are here in the LDEX. It's still a work in progress and trying to figure out how to name these groups a little bit more. This is all very kind of new for us, but yeah, so kind of, what do we do from here in terms of, one, how are we tracking these patients longer term? And two, how are we, so it's more like we just kind of wanted to put a timeline onto all of this. So this is kind of a busy slide, so bear with me. But this is basically what we came up with. It's kind of like an algorithm of how to track these patients after they have surgery and after all of their cancer treatment. So basically at the top there, it just kind of says our current surveillance program and how often we're tracking the patients. So again, like I said earlier, we're kind of using a green, yellow, and red zone to kind of classify these patients. So obviously in the green zone, this is the easiest one. All their measurements are normal, and we just kind of do typical surveillance. So we just follow them through the whole 4 years, and they don't develop lymphedema, and that's great. So that one's pretty easy. The yellow zone is again kind of what I talked about, where they're 6.5 points above on their LDEX and their RVC is 5%. Basically, we put them in a compression sleeve and kind of keep tracking them. We kind of measure them more frequently. Sometimes they kind of go, there's a couple of different things that can happen. Either they stay kind of at a similar measurement, maybe they get a little worse and kind of go up into the red zone where we'd initiate more treatment, or again, maybe they just kind of stay in this yellow zone and they're just wearing compression and managing, with, just the compression, maybe exercise, like that kind of stuff. And then basically we kind of were like, well, what do we do with these patients now? Like they're kind of sitting in this in-between zone. They're not, in the green zone where we feel comfortable weaning, but they're not, so severe where we need to really pursue like aggressive treatment. So basically, after, most of our patients are getting radiation. So once they're 6 months greater from the end of their radiation treatment, then we notify the surgery team and they get an ICG lymphography, which all patients actually get preoperatively as well. So we have a baseline on all of them, which is really nice. So we can compare. And then, so basically they get that. And then depending on how that looks, either, they're still followed by the therapy team for, again, another 6 months. And in that time, either depending on how the ICG is, we could potentially wean them out of compression if their ICG looked pretty good and we felt we could do that, or not. And basically, if we cannot wean them out of compression, then they get a second ICG and they get a lymphocytography. And basically, lymphocytography will tell us if the patient truly has lymphedema or not, and that can kind of be a good way to determine how to move forward with like our clinical decision making. Um, and then obviously in the red zone, that would be someone that, probably needs a more intensive course of treatment, maybe CDT, incorporate MLD, and more exercise, kind of a little bit, on just adding more into their treatment. And that obviously is based on the therapist's discretion and what they want to do. Um, we also will definitely notify the team at some point if, a patient is in this kind of red zone here too, to kind of figure out if surgery is warranted for them or kind of how, we want to manage them long term. But again, it's really this kind of yellow zone area is that was what we're really trying to capture in this algorithm, kind of what we do for those patients. Um, so then at the bottom here, it's basically the three different outcomes. So basically, so number one is saying that if the lymphoscintigraphy does not demonstrate dermal backflow, then they would encourage the therapist to wean off of some of the compression and see how the patients do, which would be great. And then the second outcome basically is, if they do have dermal backflow on the lymphoscintigraphy, then they kind of have that diagnosis of lymphedema. So, we probably wouldn't want to wean them off of compression because we know that that's going to manage and kind of prevent any further progression of lymphedema. So, and then the third would be, if they do have dermal backflow, there we could potentially do like an early trigger for a surgery, or maybe, at least get a full workup of other imaging and all of that kind of stuff. So those are kind of the three different outcomes. Um, so now I just have a couple cases. That's kind of it in term, and then obviously we'll kind of bring the algorithm back to every case. But I have a couple cases. So if I might kind of pause between each one and see if anyone has any questions or if they do anything differently, because this is we know there are a lot of patients out there that you guys are seeing that are probably in this kind of bucket too. So I'd love to get people's input. So feel free to, add anything to the chat while I go through these cases. Um, so this first case, Mr. D, he developed left breast cancer in May of 2023, underwent neoadjuvant chemotherapy, June to October of 2023, and he had his initial evaluation with OT and an ICG on the same day in November of 2023. His baseline LDX was negative 2.2. His volume was 1% right greater than left. He was right-handed. And then his BMI was 25. He underwent his left axillary lymph node dissection and ILR in January of 2024, and then underwent radiation in March of 2024. So this is kind of Mr. D's LDEC scores throughout the past couple of years. So basically, he underwent radiation, like I said, in March. So in April, he actually kind of went up into this yellow zone here. Sometimes initially right after radiation, they can just present with a little bit more inflammation. So sometimes, if that happens, I actually just kind of want to wait it out and see if, the numbers end up going back down. So we followed up again in a month. So then in May of 2024, we kind of ended up right back down to the green zone. So we just kind of said, let's stay the course and we'll see how things look in a couple months. And then in October of 2024, he did kind of end up into this red zone. So we decided to just start him in compression, which was in October of 2024. And then in January, he got an ICG performed, which demonstrated some linear channels, a couple areas of stardust, but definitely favorable for a wean. So basically from there, him and the therapist worked on a wean. So he's been kind of weaning. Basically, if we do any sort of wean, we'll actually have him follow up like within a month and just check in to see, how like the numbers are looking. So these past couple measurements, he was actually able to wean down to no hours in compression. And so per the algorithm, we would have him follow up with another ICG and nuclear medicine study in 6 months. But because he weaned out of compression, we actually were able to cancel the second ICG and lymphoscintigraphy, which is ideal. So this is probably kind of an ideal case of what we would like for all of our patients to be like, where they, maybe had some kind of transient swelling like earlier on, and then have been able to maintain kind of these numbers out of compression. So of course, we would love all our patients to be like this. That's not the case, but this is kind of just an ideal patient. Um, so just seeing any questions or comments about that one before I move on to the next one. Not to put anybody on the spot, but just looking. I don't see anything in the chat. So um, if anybody has anything, please feel free to add. Um, so Mrs. H left breast cancer in March of 2023, underwent neoadjuvant chemo in June to August of 2023, underwent her initial evaluation with OT and got ICG in September of 2023. Her baseline LDEX was 0.1 and her volume was 4%. Um, left greater than right. Her BMI is 22.6. She underwent her axillary lymph node dissection and ILR in September of 2023 and underwent radiation in December of 2023. I did just get a question in the chat, so I might just answer that quick. Do you typically get SOZO baseline prior to chemo? Do you see that affect LDEX scores? Great question. It depends on the patient. Sometimes we're seeing them afterwards, sometimes we're seeing them during. So it really just depends on, the consult and when they come in. So I don't think I see a whole lot of a difference, but it would be interesting to see exactly. Like I think all of these mostly I think they've been done with chemo, so I think a lot of the times we are seeing them afterwards. So I guess I don't think I have many that we're seeing before they get really any treatment because I think they're always really doing chemo first. So I'm not quite sure, but I think most times we are seeing them afterwards. Um, and then to answer the next question, how long do you recommend the patient wears compression when RBC is greater than 5%? We'll get to that. It's more of it kind of just depends on that's exactly why we kind of made this algorithm. That's because we weren't really sure before. So we will get to that in some of these other cases and see kind of how the imaging helps guide our clinical decision making. That first one was just an easy one. Okay, so that's Mrs. H, her history. This is not, there we go. So she, in March of 2024, she kind of got into that like yellow zone, like I've been talking about, and we initiated compression for her. I think her volume at this time was, I think, normal. And honestly, for these three cases, I think most of their volumes actually were in the relatively normal range. I think unfortunately she didn't get her compression sleeve in time for our next visit, so she still wasn't in compression at this time. So her numbers went up, and I think her volume definitely was above 5% at this point as well. But then, when she started wearing compression, she was, kind of came back down into this green zone, which is great. She got her first ICG in December of 2024. And basically, it did, again, similar to the last patient, did demonstrate some linear channels, a couple areas of stardust in her upper arm, but the plan was to try to wean for her since her numbers were looking good and her ICG was relatively mild. So during this time, she was actually able to wean down to 21 hours of compression. So she was still in some compression. So basically, because she was still in some, they did do a second round of an ICG as well as a lymphocytography, which was 6 months later in June of 2025. Um, and the lymphocytography did demonstrate thermal backflow, actually. So, for her, she kind of at this point has a diagnosis of lymphedema. So she's someone where we wouldn't want to wean her because, again, we know that compression can prevent further progression and it can help manage the symptoms and all of that. So we know that that's what she should be wearing anyway. So it kind of just shows that, even though her LDEX and volumes at this point are, very stable, she has that dermal backflow. So we wouldn't continue to wean her. So we would still make sure that she can manage and compression, and granted only 21 hours a week, which is pretty good compared to some of our other patients. So yeah, it just kind of goes to show that, for this one, we definitely were, had the help of the lymphoscintigraphy to understand that she actually does have a true diagnosis of lymphedema. Um, see some other, oh, still the same questions. I thought there were more. So the last case is Mrs. R. Funny, all of these have left breast cancer, I'm realizing. Um, Left breast cancer in September of 2022. Um, Underwent neoadjuvant chemo, 11, November 22 to June of 2023. She was seen by OT and got her ICG in June of 2023. Her baseline LDEX is 0, and her baseline volume was 3.5%, right greater than left, and her BMI was 33.1. She underwent her axillary lymph node dissection and ILR in July of 2023. She actually underwent her radiation locally because she lived a couple hours away, so we're actually not quite sure when she got that done. Um, So this is Mrs. R's LDEX scores over the past couple of years. So she actually, because she lived far away, she actually was seeing a local therapist. So as you can see, there's a pretty big gap from June of 2023 to July of 2024. We typically like for people to follow up at least once a year just to check in with us and take measurements, just so we have them kind of in our system as well. But within that first year, her therapist actually did notice an increase in her volume. So she did prescribe her a compression sleeve. Um, so when I met her in July of 2024, she was wearing compression. So because her number was kind of in this green zone and not too far off from her baseline, we did decide to try to wean her off of compression. However, when we did that, unfortunately, her number did kind of go up into this yellow zone here, so we kind of reverted back to wearing compression. She did get her ICG this day as well in October of 2024. Similarly, had some linear channels, a couple small areas of stardust. And then unfortunately, she kind of went up a little bit more. So basically, the therapist that was seeing her kind of amped up her treatment a bit more. She had her incorporate self MLD, got her a tighter sleeve, and then she actually did kind of shoot back down here into the green zone here, which was great. So, some of the conservative treatment that we had recommended really worked for her. And then 6 months later, in July of 2025, she did receive her second ICG and the lymphoscintigraphy. And the lymphoscintigraphy actually did not demonstrate any dermal backflow, which again is showing that at this point we're not going to diagnose her with lymphedema. So the plan was for her to start weaning in the next couple months. So again, this is just a different outcome where, now this patient, because she doesn't have lymphedema, the plan would be to try to wean her and see how she does with, her measurements and symptoms and all of that and keep tracking that moving forward. Um, so those are the cases. Basically, just to kind of sum things up, all three of these cases definitely had different outcomes, which is why I thought they were, interesting to discuss. And basically, this algorithm has been able to, allow us to figure out what to do for these patients and kind of aid in our clinical decision making. And so in the future, you definitely want to, of course, as you can see, some of these are from, a couple months ago. So this is all still pretty new to us. So we definitely want to keep tracking these outcomes long term and see kind of how these patients are a year out. And I think the plan will be to get further imaging on them and kind of compare that to their previous imaging. So kind of figuring out, next steps of how this works long term and keep fine tuning the algorithm. Um, any questions, comments?
Great. Thanks so much, Katrina. That's a great overview that I know, again, it has been an evolution over the last couple of years of how to fine tune this, and I'm sure it will continue to change over time. If there's any questions, feel free to put them in the chat, or I can, if you raise your hand, I can take you off mute if you want to ask it. Otherwise, Katrina, maybe not so much a question as a comment, but it seems like this has been parallel to our overall move towards evaluating patients earlier in their phase of disease and maybe even offering procedures earlier on. This is a unique data set in terms of patients that have already had some intervention done
Yeah,
prophylactically. But it seems like we're moving towards maybe offering these patients something like a lymphatic venous anastomosis earlier than maybe we would have 5 years ago when we started the program 5, 7 years
yeah,
ago.
yeah.
Um, so one question kind of to dovetail on that is how do you feel patients they are how do they accept going through all this extra kind of visits and work? Are they happy to do it generally? Are they glad that the program exists, or are they more of like they're overwhelmed with their other, therapy? They may be undergoing active breast cancer treatment. How have most patients responded to the program?
Yeah, that's a good question. It's been very mixed. Like actually, I'll say that actually one of the patients that I discussed about was definitely overwhelmed and confused by all the different because it's a lot of, long words and it's definitely confusing, especially also coming off of just having breast cancer treatment. And all of that is obviously still so confusing. So yeah, it's definitely mixed. I think some people are obviously very motivated and don't, want to know if this is something they need to do long term. And especially if, you're kind of phrasing it as, well, this will kind of tell us if, compression is something you need to wear like for the rest of your life, or if this is something that we could potentially, wean off of. And I think that's definitely a motivating factor for a lot of patients, because obviously they don't want to wear it if they don't have to. So it's definitely mixed. I would say, most people are on board with it. A lot of them, are very health literate and are trying to advocate for themselves. So a lot of them are okay with it, but definitely been mixed. And some, I think, honestly, you know, don't really want to go through all of it. Some of them are
Yeah.
kind of like, I'm okay with where we are right now. So definitely
Yeah.
mixed.
Well, I think from a pure clinical standpoint, it's a wonderful program, and I know there's variations of this at other centers around the country, but I think we all can appreciate that getting on top of these patients early and getting them engaged with their own care, because it is such a disease that they have to do much of the heavy lifting themselves.
Yeah.
So making sure that they're being surveilled and catching it early, and at least so they know that what options are available, non-surgical and surgical.
Yeah, and I think some people early on may not really understand all of like the management, what it takes. So sometimes it's a lot of education on, what lymphedema is and what it can progress into, especially, and again, it's like, this is really great that you're in some program like this where you're monitored so closely and so frequently. Because some people just don't really realize that this is, there are a lot of other patients out there that didn't get a chance to get this kind of care. So
Right. Right. Well, thanks again for taking the time putting this together. I see hold on, one more question popped up. Really good to see the case studies and the trajectory of measurements and intervention over time. It's from Angela Sarah. And here, how